Thank you. Thank you very much for inviting me to speak at this meeting. For those of you who don't know who I am, my name is 𝗏𝗏𝗃, and I'm a vascular surgeon from the UK. I very much feel like this session is a bit of catharsis for those of us that have been asked to stand up here, and I will stand up and admit all of my sins. I've called this the Nightmare Before Christmas because this happened on the 16th of December 2009. I had been a consultant for about 3 years when this happened. I was on call and an 86-year-old lady presented to a local A&E department with abdominal pain and back pain. And she had a CT scan in the morning, showed a large aneurysm but not ruptured, with a chronic occlusion of her left common iliac artery, or in fact iliac system. They discussed it with us and we said, if her pain's settled, we can see her within the next 2 weeks and we'll sort out repairing her aneurysm. Unfortunately, they rang us back a little bit later, so in the afternoon, and said that she was preparing to go home and she'd collapsed and dropped her blood pressure, and they thought that clinically she'd ruptured, and so we said send her. So actually the CT scans I've got don't show a rupture, because these were the ones that were taken in the morning when she hadn't ruptured, and she was too poorly to have a CT scan after she'd ruptured. But just to give you a few details of her aneurysm, she had a very tortuous proximal neck. It was a big aneurysm. And this is her iliac system. If you can see, she's got terrible iliac artery disease, typical for elderly women who smoke. So she had a completely occluded left system and a very small right common, and quite calcified and tortuous. So those were the CT scans. I told you that she collapsed and we took her. She was quite a frail little old lady and she was known to have COPD and had limited exercise tolerance. So we decided she wasn't fit for open surgery. So this was her angiogram on the table. She had a single left kidney as well. And this is us deciding to do endovascular repair with what I have to say now looks like a terribly diseased, horrible proximal neck just underneath her left renal. We were going to do an AUI. You can see the tortuosity of the aneurysm, but also the inhospitable neck. We decided to use a Cook AUI because that was what we had on the shelf. And you can see us trying to get it into position just underneath the left renal to try and maximize that horrible neck. So this was the angiogram after we had deployed the whole thing. So an AUI down the right system. You can see she's got a renal artery, but there is this clearly obvious proximal endoleak filling the sac, and it filled rapidly, and you can see it's coming round the side of the stent graft and then filling the sac of the aneurysm. Now, it wasn't very big, and I have to say that maybe with the retrospectoscope, I may have accepted this as an angiogram and taken her off the table. But because she'd ruptured, we felt at the time that we should chase this endoleak and try and stop it. So you can see that the radiographer thought we'd finished, because this was the next picture where she'd labelled the image thinking that we were done. So we decided that simple thing we could do to try and get rid of the endoleak would be to just balloon that proximal neck and see if we could get rid of the iliac, so get rid of the proximal endoleak. So this is us with a balloon in the proximal neck, trying to balloon it to get it to conform to that neck. And this was our angiogram after we'd done that, which I have to say was much worse than the original angiogram. The endoleak was much more rapid, and it was definitely still there. So we had a long discussion about what we should do, but we did think, although it's not very obvious on this angiogram, that actually there was a little bit of a space between the bottom of that left renal and the top of the Cook stent graft, and that maybe we could put a cuff in. I think it's a good point to say at this stage that this was being done under local anaesthetic. The only access we had to do angiograms, etc., was via this right iliac system. So that's a better picture showing you the gap between the renal and the top of the stent graft fabric, which is sitting, I'm not very good with this pointer, there. So this was me. I have to hold my hand up because it was my error with a Cook cuff. So with suprarenal fixation and a 5 centimetre cuff. And this was me trying to get it into the best position I possibly could to maximise that residual bit of neck. And then it was at that point that I made probably the biggest technical mistake I've ever made in an operating theatre. So for those of you who've deployed a lot of Cook stent grafts, they've got safety wires on them, and the Cook cuff has got safety wires on. It's got one at the bottom attaching it to the device, to the delivery system, and it's got one at the top, which releases the top cap. It was quite fraught by this stage. I haven't probably filled the atmosphere of theatre, but she was elderly, it was a rupture, she hadn't been very well. And I did say, do I take both of the safety wires off now? And I can't even remember whether somebody replied, but I did. I took both of the safety wires off. I took the bottom and I took the top off before I pushed the top cap off. And the problem with that is I now had no control over the cuff. So I nothing to hold on to. I couldn't push the top cap off. So I was stuck with the cuff in the aorta, a top cap that I had no control over. When I pushed the device, it just went further in. I only had access from the iliac, and so really stuck now because I'd probably made a mistake. Just remind you of her terrible iliac system. We thought about it because I couldn't get the device out, obviously. I had to try and get that top cap off somehow. So I put a balloon, we managed to eke a balloon alongside the delivery system of this terrible iliac artery all the way to the top to try and hold the cuff with the balloon so that we could then push the delivery system off the top. But we couldn't do that either. And so I was still stuck in a situation where I had an open cuff but a stuck delivery system. We thought of lots of different things. We thought of coming from the arm and trying to snare the top cap and pull it off. Again, she was under local anaesthetic, and we did prep the arm. And then I thought, what can you do? I'm in real trouble now. I'm going to have to phone a friend. So I used to work at Guy's and St Thomas's, and my friend was 𝗏𝘀𝗱𝗆, who was my boss and my mentor. It was Christmas, and it was 2 weeks before Christmas, and he was at a boozy Christmas dinner for those foodies in the room, 𝗏 de la Tour, which is a very posh restaurant by the Thames. And to say that he'd had a few beers, wines would be the understatement. But despite being tipsy, he did answer his phone to me. And he came to St Thomas's with his wife, who was also a bit tipsy, and sat in the control room of our hybrid theatre, and we discussed, him a bit tipsy, me scared out of my mind, what we could do to try and sort this out. At about the point I thought things couldn't get any worse, in trying to use the balloon to push off the top cap, we ruptured her right iliac system. She dropped her blood pressure again. We put her to sleep, and I had to cut down on her iliac system to control the bleeding. At this stage, the device is still stuck in her, so I've got the whole delivery system going through the ruptured iliac, and I can't push the device up, and I can't pull it down. And so, in consultation with my, it'd be fair to say, and he would admit this, drunk colleague, who had the most epic endovascular experience. He said to me, "You've got no choice. You're going to have to leave the whole of the delivery system in her and cut it off at the point at which the iliac is ruptured." I knew that was going to happen, sorry. Using some device from orthopedics, I cut the device off in the groin. And just in case you think I'm lying, this is her post-op chest x-ray the next morning, and you can see the delivery system of the Cook device that was still inside her. She was not dead, though. That's why she was having a chest x-ray. And the good news is that despite all of that mess, she did not die. Her aneurysm thrombosed. Just to point out, I revascularized her legs by doing a bilateral 𝗓𝗏 graft. And over the metal spiky bit that was coming out of her iliac, I wrapped some Teflon around it and sewed it into her right iliac fossa. She did survive, and she left hospital relatively unscathed, although she found it very difficult to bend down, which might have been the steel rod that was going from her right iliac all the way up into her chest. Her daughter told me that she found it difficult to tie her shoelaces, so we solved that problem by giving her some slip-on shoes. A year later, I duplexed her. She died 3 years later from pancreatic cancer. Sorry. And just so that you know, she didn't die. This was her duplex scan of her graft just over a year after her repair, which showed that her aortic stent graft had thrombosed and that her axilla bifem graft was patent. I don't know what the moral of this story is. Firstly, know how to use your devices. Secondly, this was entirely my fault. It had nothing to do with the device. I was very honest with the patient and the daughter, and she was very grateful that her mother was still alive, but it was a catastrophic error that haunts me every time I'm in an endovascular suite. Thank you very much.